Bismillah ar-Rahman ar-Rahim. Welcome everybody again to our continuous educational program regarding different topics in the retina, especially who the people are interested in the retinal diseases. Today I'm addressing a very important topic, which is a macular hole. Macular hole is very old, and it has a lot of updates every time. There is update in science everywhere, but especially with the macular hole regarding the diagnosis, the technology, even the classification of it, which will be implemented also in the prognosis and the prognostic criteria. Let's take it step by step, and I think I'm quite sure at the end of the presentations, everybody will know exactly how to handle the macular hole cases. What is the classification of the macular hole? IVTS is the international application of the study group, of the macular hole study group, and the classification of the full thickness macular hole. What's full thickness macular hole? As you are seeing the pictures here, it has the anatomic defect in the fovea, interruption of the whole neural layer of the retina, starting from the ILM to the retinal pigment epithelium down there. And we have aperture, we have size of the hole. We have to measure the size of the hole, of course, with the OCT machine from the narrowest part of the hole. As we see here in these areas, we can measure the aperture is almost like 192 micron without any overlying tissue adherent to it, without vitreomacular traction on it. So this is clinically evaluated based on the international vitreomacular hole study group classifications, and require careful and approximate OCT studies. A macular hole, as we know, it's full thickness defect for the people who like the literature way of talking. In the neurosensory retina, idiopathic full thickness macular hole has many reasons. Of course, we will talk about the reasons of the macular hole, but idiopathic macular hole is the most common. It's important cause of central visual loss. The lesions are twice as common as in female and male, and 3/4 of the affected individuals are over the age of 65 years of age. The population prevalence of macular hole is estimated as being 0.1% individual aged 40 years or older, and 8% on those aged over 47 of age. Macular hole causes, we have many causes and many risk factors. I just put here with the reference for people who like that, but the most common cause is idiopathic macular hole, and it comes to secondary macular hole. Idiopathic is primary macular hole, and the secondary macular hole has a lot of causes regarding this, but the most common cause is the idiopathic, and it represents about more than 50% of the cases of the macular hole. It always happens during the time of the PVD, with the PVD, which is normally occur after the age of 50 and reach to after age of 60. Most of the people has total posterior vitreous detachment. At the time of the posterior vitreous detachment, sometimes a macular hole can evolve due to the tractional image exertion from the anteroposterior traction, or it will come later from the epimacular membrane from the tangential traction as well. The causes, as we see here, we have three different types of a hole, as you see in the pictures. Vitreomacular traction theory, which is will be implemented in the idiopathic type, and the trauma is the second one. Most of the patient has experienced trauma, especially the plantar trauma, due to the countercoup injury or the compression of the group, sudden compression of the group from the through its anteroposterior axis can lead to macular hole, or progressive high myopia due to stretching of the glue with the thinning out of the retinal layer, and you know that the most thinnest area is the fovea, so it can break out and lead to macular hole as well in such instances. Sometimes with the people with long-standing retinal detachment, rhegmatogenous type, due to separations with the fluid accumulation under retina, can lead to macular hole as well, and less than 1% of patients who successfully repaired even rhegmatogenous retinal detachment can experience macular hole. If we take a look about the pathogenesis, and basically I like to talk about pathogenesis because actual understanding of the pathogenesis will lead to exactly to know the causes, so you can hit exactly the reason for the hole and you can treat it in proper way. The pathogenesis here, if you look at idiopathic macular hole, full thickness hole, are caused by traction exerted by posterior vitreous cortex on the neurosensory retina at the fovea, this is first, or this insertion of the glial plug result in formation of foveal cyst. And the second, avulsion of the cyst roof, or we call it deroofing, can lead to suspected posterior vitreous cortex, and the neurosensory retina after that retract centrifugally by the tangential tractions around the hole, lead to widening of the hole. For the development of the hole as described by Gass, which is the godfather basically of the whole retinal diseases, he actually described how the hole happened. If we look at the first picture, that's a normal, healthy retina with all integrated layers, as we see here. We have stage 1A and stage 1B. Stage 1A in bending hole and also stage 1B in bending hole. But what is the difference? The difference in 1A, it's early contraction of the outer part only of the vitreous cortex with foveolar detachment. But when it is a little bit larger and including the whole fovea, not the foveolar, the foveal detachment, it will be embedded in stage 1B. It will appear clinically at a yellow ring under the fovea, but with intact surface up till now. Then we will go to stage 1B, which is occult hole. Occult hole, that means it happened, a retinal receptor layer detached from the vitreous with a centrifugal retraction of the receptor as well. After that, which is stage 1B, which we said hole, now we go for stage 2 hole. Stage 2 hole and stage 2 hole also, we have two stages in hole. Early separation of the condensed perifoveolar vitreous cortex with formation of a pseudo-operculum that is larger than the hole itself. The operculum is larger than the hole itself. But with the stage 2 hole, tear in the vitreous cortex at the junction of the perifoveolar cortex at the edge of the macular hole, not over the macular hole itself. All this descriptive basically it goes to the anatomy. Sometimes it's hard in real life to exactly differentiate between these kind of stages of the hole, but with the OCT, especially with the spectral domain OCT, it helps us a lot with that. Going down for the stage 3 here, stage 3 hole, which is a pseudo-operculum, no posterior vitreous detachment on this patient, still the vitreous is attached. When it is separated, we go directly to stage 4 hole, and the size actually getting larger and larger in that. Staging with idiopathic, if you look at that, you can follow. This is normal fovea going to impending with only foveolar separation. The stage 1B is occult, still attached. Photoreceptor is detached, but still no detachment, no operculum. And going to stage 2 hole, which is the separation in the underneath from the photoreceptor cell has been separated and still attached also operculum. And the stage 3 is the larger than at the operculum side, the larger than at the edge of the foveolar. And in stage 4, there is total posterior vitreous separation. This is how to follow the progress or the staging of idiopathic macular hole. About the history of that, initially, the symptoms include blurring of central vision. Most of the people come with the blurring of central vision. Or rarely, some patient may describe the exact moment at which the hole develops. It needs, of course, very skilled people to taking aware of themselves, because of course we have both eyes, so it's hard to examine each eye. Or accidentally, most of the people when they're driving and try to blink with other eyes, they discover something in the other eye. So accidental discover is more liable in these instances. Later, a larger macular hole may produce central defect or scotoma. Some patient may be asymptomatic at all and only diagnosed during a routine ophthalmic examination, maybe for glasses or anything. How it looks like that. Just here, when you look at this with a vitreomacular traction, but no hole still, according to the NICE. What's NICE? NICE is the UK National Institute of the Health and Care Excellence, is NICE. Cited here, they put that for the specialists, they can look at, if you look at the such road, you can see corrugated lines with the vitreomacular traction. Exactly, when you go from the normal, which is the upper top, go to the middle, when there is vitreomacular traction as the OCT demonstrated here, you can be reflected in real life on this irregular line or wavy line, especially during driving. Or actually, when the whole exactly it happened, it can lead to central scotoma. You can imagine the life is like that. You don't see the central part of the road or like that. So this is the follow. This is the normal. This is the only with a vitreomacular traction. And the last one with actual macular hole presence. Physically, how it affect, how the patient will say, will complain. The exact complaint is different, as I said, from the culture to culture, but with the visual acuity of the patient varies according to the size, locations, and the stage of the macular hole. Patient with a small eccentric hole may have nothing. Vision is completely normal because it didn't affect the fovea itself. But in addition, macular hole is not, if not full thickness, can have a good visual acuity as well in the range of 20/30 or 20/50 at maximum. But however, once the macular hole is well established and well developed, a full thickness, usual range, it ranges from 20/80 and less, up to even 2400 or even less if the detachment happens. So different presentation regarding the vision is also liable with the macular hole according to the size and the site and the configuration of the hole itself. With biomicroscopic examination, a round, excavated, well-defined border interrupting the beam of the slit lamp. We call this the Watsky sign, Watsky-Allen sign. You dim the light, you shorten the light, you even the broadness of the slit lamp beam to pass interrupted. If it is passed through rear hole, you will find interruption of the beam light. In most patients, an overlying semi-translucent tissue representing the pseudo-operculum can be also suspended over the hole itself. As we see here, we can see here different type of hole. This is a hole in the top upper pictures, and in the lower hole, it's chronic hole with the lipofuscin deposits, yellow deposits. Sometimes you see it in the deep layer of the hole, and we can see most of these lipofuscin deposits in the long-standing hole, especially with the post-traumatic holes as well. Many diagnostic signs, I can use it. I can use, as I said, by microscopic. It needs a well-experienced and trained physicians, retina specialists, to look at the Watsky sign. You have to make dilated pupil and put the beam during the hole itself. Or actually, I can use also the laser aiming beam also in the performance similarly way. I can use a very small spot of 50 micron, and I can put this 50 micron outside the hole. The patient will be predicted, and you see, I see the red spot. But if you put it in the hole itself, and there is a real hole, the patient will say, I don't see anything. So you can differentiate from the dehiscence from real hole to pseudo holes by this test as well. In addition, slit lamp and some slit lamp has equipment you can put figures as well, like stars or something like this. You can put these stars to be perceived by the patient outside the hole and inside the hole for comparison as well. This is a different way. Of course, OCT add to this, but I'm talking about the clinical first experience. You should have a high clinical sense to order an OCT. You will not go for every patient to do OCT just to suspect. If I suspect, I have to go for OCT for more documentary, quantitative and qualitative issue as well, to study the other thing as we will see later. On the clinical staging, as I said, all this on anatomical staging. Clinically, macular hole formation typically evolved through a series of 4 major stages, which were first detected according to the biomicroscopic feature. As we see here, stage 1, hole. If you look at the depths of the OCT, you can see like small elevation or dehiscence of the inner layer of the retina. So this is a stage 1 hole, impending macular hole, loss of the normal foveolar depression associated with the development of yellow spot, which is stage 1A, and stage 1B. It depends on the side of this dehiscence. In the center of the fovea, changes that reflect the intraretinal schisis that progress to intraretinal cyst. Stage 2 hole, here we will see a full thickness hole, but less than or equal to 200 micron in size, typically with pericentric configuration associated with sometimes vitreofoveal attachment. Still the vitreous attachment and may exert some traction on the hole itself. And the stage 3 hole, if you see here, you can see in the OCT, there is a hole, it's a little bit wider than normal, might be more than from 250 to 400 microns, that's stage 3. And you can see the floating operculum on the still attached posterior hyaloid on the top of the OCT, as you are seeing here, going finally to stage 4 hole, which is larger than 400 micron, 450 micron size hole, and actually there is complete vitreous detachment. You cannot see any kind of relation between the retina and the vitreous interface in this hole. This is the clinical stages we mostly see. As we see here, early macular hole and macular hole 5 years after onset. What is the difference? If it's clear enough for you, you will look at the right here, you will see some lipofuscin deposits in the base of the hole, indicating the chronicity of the hole. And in the first one, you don't see this for the small hole and don't have this pigment. Now we know the hole, we know how to diagnose it either in real life or with the machines or with our different techniques I just mentioned. It could be also misleading. There is differential diagnosis should be kept in our mind, the differential diagnosis. What would mimic the hole? What would simulate the hole? Primary consideration should be given the conditions that mimic the appearance of the hole, while most of the consideration are rapidly apparent clinically. An appropriate workup, I should do it to identify these conditions. Differential diagnosis of a stage 1 hole may include like cystoid macular edema for any reason, diabetic, renal vein occlusion, retinitis pigmentosa, it can mimic. Also, differential diagnosis of full thickness macular hole include pseudo hole. People who have epimacular membrane, sometimes the whole membrane it may mimic the hole itself. So clinically, I can differentiate between both. Like here, central serous is self-limiting disease in the middle age, of course, usually unilateral, localized yellow detachment of the sensory retina, and often outlined by glistening reflex. There is no real dehiscence. For the opaque membrane, I like here, you can see opaque membrane and you see macular hole. Here I'll give you a very good sign. You can see the tractions of the vessels from the epimacular membrane. Macular hole alone cannot do this. And also the configuration of the hole, it's eccentric. Eccentric, that means there is some kind of epiretinal tissue exerting. So it could be a hole, secondary hole, or pseudo hole. The only difference is there is dehiscence of the retinal layer or not. The patient can perceive light or not. The patient can perceive laser beam light or not. This is the difference in these two cases. And also diagnosis of cystoid macular edema, of course, loss of the foveal depression and yellow spot in the fovea, like this. Is this any investigation I can do? Yes, we can see most of these cases of the cystoid macular edema. Mostly we see this in diabetics and vein occlusions. If you leave it for long standing, deroofing of one of the cysts or the middle cyst can lead to secondary macular hole, as you are seeing here in the graphs. Important cause like cystoid macular edema, I can see it in retinal vein occlusion, as I just said, diabetic retinopathy. I can see it also in post-cataract surgery, Irvine gas syndromes. I can see it in also intermediate uveitis as a secondary inflammatory cystoid macular edema. Differentiating between full thickness macular hole and pseudo hole on the base of the clinical feature alone, it's a little bit difficult. So subjective distortions with the Amsler grade, it's very important. And the fundus and the laser aiming beam is very helpful in that part. But the most recent, after all that, you should understand the basis of the science. But with the OCT, advent of the T, especially with the spectral domain, OCT is very helpful in such cases because it gives me high resolution cross-sectional imaging of the retina. OCT allows the physician to detect also the presence of any macular hole as well as the changes of the surrounding tissue. Not only the retina vitreous relations, sometimes interface any traction, any partial traction, any complete separation. Also distinguish lamellar hole from cystic lesion of the macular hole, and also the status of the vitreomacular interface. As I just said, it allows the clinician to evaluate the earliest of the stage of the macular hole as well as evaluate the other vision limiting condition associated with the macular hole, such as surrounding cut-off subretinal fluid accumulation at the edge of the hole. All these things will be apparent by OCT. Fluorescein still has a room, yes, still has a room, but it's not conclusive. It's not my primary line of treatment. It may be additive. You may be for the first visit, you can make fluorescein, but it will not be a solo or single description or for a diagnostic tool. Full thickness macular hole, yes, I can see here. You can see full thickness macular hole, as we just said. There is a stage 3 hole. We see here, we can see in the OCT some fluid accumulation or cystic change at the edge of the hole. But in the fluorescein up, I can see no late pooling of the dye with the progress of the stain. So OCT is, of course, definitely superior than fluorescein in that part. But of course, the states will be different in the cystoid macular edema. Cystoid macular edema, as we see here, the betaloid pattern of the Irvine gas syndrome, as we see here in the fluorescein. But in the OCT, it's clear cut that there is no deroofing of the cyst. It's just edema. Even it's very thin. Sometimes it's difficult clinically to detect that. But with the OCT, it's of help. With the central serous retinopathy, yes. Of course, we know the typical pattern of central serous retinopathy, and we can follow the OCT with that. With the central serous retinopathy is a smokestack pattern that increase with the stages from the early fluorescein, mid fluorescein, and late fluorescein with the late pooling. Sometimes give a typical umbrella or atypical umbrella, or sometimes rarely it can give me my ink blot pattern, as we just see here with the progress of the dye. But definitely OCT tell me there is no dehiscence of the neurosensory retina, is still completely intact. Epimacular membrane, yes, epimacular membrane with pseudo hole, it can give me that. We can look at the fluorescein, how much corrugated vessels down. That means something is grasping this area like this. This is a membrane. Of course, if you continue, that's stage 3, and the OCT here is very evident. You can see that a pseudo hole in the fibrous tissue, or actually I can go for the lamellar hole, not complete hole, because still the lower part which carry the photoreceptor is still intact here. So B-scan, yes or no? I will just put it because it was used in the past. It can tell me with the hole, especially when it's attachment, especially with the cystic, but of course it need very large hole or very large cyst to be evident in B-scan, so it's not of use nowadays. And that's the way of Amsler grid. It can be on a paper, still paper, or it could be in a screen as well. And people will look at the center of the Amsler grid, and he can notice the changes daily. If he has impending hole or something like this, I can give it to him. And in most of the countries right now outside, of course, Amsler grid can be used for all macular diseases, as we all know. They put it in some countries on the newspaper, on the upper top for the newspaper. That means mandatory for every patient. When you look at the newspaper, he can test his eye, which is eye as impending danger. For such case, any corrugation or any new change of the corrugation of these vessels can be, of course, reported, and he should visit his retina specialist. Of course, they put in newspaper, but I don't think that nowadays people are still reading newspaper. People are going for electronic now things and seldom using that. But anyhow, it was used. Microperimetry and the multifocal ERG, yes, it can be, because it gives me defective response in the area related to the hole itself. Of course, if I don't have a hole or pseudo hole, the microperimetry and the electrophysiology will be normal values. Now, we know now the hole, how to diagnose it, how to also exclude any other mimicking conditions. That means in going in the differential diagnosis categories, I have now a macular hole. With different stages, I know the different stages, and I can. What is my treatment strategy? And when I treat, and how I treat, this is very important. This is changeable things according to the new technology with the new advent of some medicines for that as well. In the past, all the strategy, I have to treat full thickness macular hole when the visual acuity goes less than 20/70, and the duration, if it's say less than 1 year, I can treat the macular hole. How I treat? I treat by just observation, the hole, or I can do vitreolysis, or I can do vitrectomy. What's observation? Yes, observation, because in 10% of the macular hole, it can resolve spontaneously. How? If we go to the pathophysiology, remember that the traction from the vitreous and the contraction and all the things. So if the normal separation of the posterior vitreous detachment happened and completed, so this tractional element on the hole, when it resolved in 10%, it can close the hole spontaneously. And if we follow such case, yes, this is one of my patients in June 2013. You can see stage 1A hole, and in Jan 2014, it is stage 1B, we can see more dehiscence. And if you go June 14, every 6 months I saw those patients. It's increased the hole. The hole goes up here to now impending stage 1 hole. And in January 2015, this year, the hole is increased, so is grade 1 hole, but with enlargement. But when the separation happened, this has happened. And you can notice the separation very evident in the central OCT picture, that the hole is closed, all the criteria of hole is closed. That's in June 2015 with the full separation. So just the full separation of the posterior vitreous can lead to closure of the hole and a portion of the whole process. But this is not the scenario in every case. It's only in 10% of cases. So observational is one of the treatment option. It may go to that scenario, and it will be thanks God if it goes to that way. Now, if you look at this graph, it gives you just tell you that early intervention decrease permanent visual function loss in patients with vitreomacular traction. Here, the watching period is very important. As I said that, if you look at that and you follow that with the OCT to see if any exerted traction of the whole, early intervention carry better prognosis. I would see that, yes, early intervention. You can see such membrane. It's still membrane, incomplete membrane, epiretinal membrane, with, of course, a portion of the, or actually the inversion of the, instead of foveal depression, it's a little bit elevated. That's in Jan 2014. In June 14, membrane become more evident, more continuous, that has some focal attachment to the retina with a little bit exertion of traction over it. And in January 2015, it's become attached to the central fovea, detaching or actually elevating the fovea more and more. And here I interfere in that part. I'm not waiting. Why? Because I can see the progress. So I'm not waiting. I just remove the membrane in June 2015, and this is 1 month after surgery. I can see almost normal anatomy without any implication or any inflection on the visual acuity of this patient, and it get improved, of course. So here, early intervention is a value, especially when you follow up your patient thoroughly. Prolong it? Yes, if I follow. This is a follow-up of the other patient I had. I'm not intervening here in this patient in the proper time. That's Jan, almost the same, but that's Jan 14. In Jan 15, after 1 year, he has hole, the Miller hole in that part. And of course, I have to interfere at that stage also, not to leave it full thickness hole, and the retina is good. And actually, even the neurosensory layer and the ellipsoid segment, which carry the photoreceptors, is completely restored, and the vision is restored as well in March 2015. That's the fellow eye. So, in the vision, in the past, I have only 2 treatment options, which is either observation or go for vitrectomy for such a case. When I see like a traction like this and impending rupture, I can relieve the traction with vitrectomy. It's a little bit, of course, we know that it's delayed, it's invasive, surgical risk, of course, we know the surgical risk and the complications that might happen for this patient. Nowadays, yes, there is another thing goes in the treatment plans, which is a pharmacological vitreolysis. We use that, yes, pharmacological vitreolysis, instead of just watching and go for vitrectomy. In the middle, there is a place for pharmacologic vitreolysis with the ochriplasmin, which is the earlier treatment, minimally invasive, and it relieves the vitreomacular tractions, and it can lead to macular hole closure. So what's ochriplasmin? Ochriplasmin, or its name, commercial name is the Jetria, the need of an enzyme to split the vitreomacular interface, which is formed by strong adhesive interactions between the posterior vitreous cortex and the internal limiting membrane, lead to production of the ochriplasmin. The ochriplasmin, it comes like that, as FDA approved in 2012 and in European approval in 2013. It is actually a recombinant human serine protease plasmin with proteolytic activity against the protein component. It dissolves the protein component, either laminin, fibronectin, and collagen of the vitreous and the vitreoretinal interface, thereby facilitating the vitreous liquefaction and the separation of the vitreous from the retina. So I will lead to pharmacological, non-surgical PVD. That is the aim of the drug. Intravitreal oculoplasmin is indicated for treatment of symptomatic vitreomacular traction or adhesion when associated with macular hole of diameter less or equal to 400 micron in adult patient. This is the scope of the treatment of Jetria or oculoplasmin. We have some predictive criteria. We have 4 predictive criteria, very important. Age of the patient, younger than 65. If it's present, it's good prognostic. No ARM, no epiretinal membrane. If it's present, it's good. Vitreomacular adhesion, the diameter of the adhesion itself is less or equal than 1,500 micron. And the phakic status, if the eye is phakic, it carry better prognosis than the pseudophakic eyes. If these 4 criteria are present in the case with vitreomacular traction, so in this study, the relief of the traction or the successful separation of the vitreous, it will be in the range of 75%. Release of the adhesion at day 28. So almost after a month from injection, so 75% of these cases succeeded to complete BVD with the release of all pathology that may lead to macular hole formation. Presence of only 3 out of the 4 predictive criteria will give you the incidence rate of separation by 50%. Closure of the macular hole in this study of 400 micron or less give a closure rate of 75%. And here is a reference for the people who are interested also. Another study of Marine et al. Has confirmed the vitreomacular traction in 71%, but Sharma et al. In his series give only 50%. It range. In a prospective study of Zhang et al. In his series, he documented a release of the traction, which will be reflected in the visual acuity. This is a study, only study, and only look for the anatomical release. It will improve the vision or not. Yes, this guy, he said that there is improvement in the visual acuity, both separation as well as of the central foveal thickness by the OCT. It has side effect, nothing without side effect. Of course there is side effect. Side effect in the study addressed in another study, the most demonstrative was Hajar, and who conclude that newly developed subretinal fluid has been described after oculoplasmin treatment, predominantly in cases with resolution of the vitreomacular traction. It could also be detected after vitrectomy, which persists for several weeks up to 7 months. Even after vitrectomy, you can remove the vitreous nicely and all the separation, and you still in the OCT for a few months after surgery, you can find this fluid. Why in this case of oculoplasmin may be attributed to the photoreceptor complex, loosening of the photoreceptor complex due to the enzyme activity of the oculoplasmin. It is documented. Here we can see some cases. Of course, one of the typical cases of oculoplasmin. You can see focal traction into secondary edema. It's impending. That's before injection, and it's 1 month after injection. Of course, you can see still residual fluid, because I said this fluid, subretinal fluid, can persist for up to 7 months even after surgery, but it will go spontaneously. If we see here, yes, there is adhesion, focal adhesion with macular hole grade 1, grade 2, and that's before injection, and that's 1 month after injection, and that's 2 months after injection. You can see here, what's the difference between 1 month and 2 months? You can notice the diminution or the resolution of the subretinal fluid. And if you follow this patient more and more, you will see complete resolution of this, and it will be reflected on his post-operative visual acuity or post-injection, basically. Pharmacologic repair of the macular hole. So we know now that the oculoplasmin can be used for selective cases, some selected cases of impending macular hole, grade 1 or 2, as a non-surgical posterior vitreous detachment agent. As you see here, is very demonstrative. Look at that, and you can follow after 1 month, 2 months, and 3 months post-injection with the spectral domain, and even up to 7 months is the lowest one. You can see almost normal configuration of the retina. It takes almost 7 months for complete resolution of the subretinal fluid with good visual acuity results. So Jetria is proven beneficial as a safe technique for focal vitreomacular traction and macular hole treatment. Okay, we know that now, and it's proved not by me, in many studies all over the world in the last 2 years since it's FDA approved. But there is still controversy about its use in other entities. Sometimes when I have macular edema, diabetic macular edema, and I have some focal traction. In the past, we said there is traction or no traction. If macular edema alone, you can go for injection, other injections like anti-VEGF material or steroids or whatever. If there is traction, I have to go for surgery to relieve the traction. But does Jetria has some rule in that it can relieve this traction? Yes or no? There is controversy because people addressing that. No, because the adhesion is different. The pathology is different. The protein present in the adhesion for the diabetic is different. But we address this in I did my study myself. I include 24 patients with vitreomacular traction in diabetic patient with secondary diabetic macular edema, and they did show that there is 56% rate of release of the adhesion. Sometimes works, sometimes it's not. It depends on the site and the size of the adhesion. Some favorable, yes. We can show this patient in August 2014. I can see some focal still attachment with edema. I did my injection with Jetria, and there is separation, and this is the patient after 1 month from injection. The edema is less definitely, and if you look at that in December in the same year, after 3 months, the edema is almost disappeared without any other injection needed for this patient. Also another favorable, you can see here, focal edema in the middle of the OCT in Jan 14 with attachment of the posterior hyaloid over it. It's localized. Here you can notice the separation, how come it is. And we can follow even the separation of the posterior hyaloid is already separated up and also down up to May 2014 was almost a normal foveal configuration for this patient. So also favorable prognosis, you can see here, I have secondary macular edema here with a still attachment of the posterior hyaloid. So when I relieve this posterior hyaloid attachment, you can see here, it is separated, the posterior hyaloid is separated, the edema become only focal, and it disappear completely, maybe after 5 months or 6 months from posterior vitreous separation. But sometimes I can face this also. Failed response. I have this, I can see still the attachment of the posterior hyaloid. I wish it relieved with Jetria. It's relieved with Jetria. It's no longer attached, but the cyst is there. It's separated here. You can see the posterior vitreous is separated, but the cyst is still there, even become more and more bigger. So sometimes you don't have clear guidelines for which membrane is separated, which vitreous liable to separate. But from the preliminary observation, it said that with the focal, whenever it's focal attachment, it's more liable for dehiscence with the pharmacological agent rather than diffuse or surface attachment. It will be very difficult for those patients and will give you a failed response. So indication of macular hole surgery. Now, we go for the third line. We said there is observation, because we know that 10% of the patient may resolve spontaneously after BVD, or we go now for the pharmacological vitreolysis in the macular hole cases, and we see how to implement, and we know now the predictive criteria, and we know how to can predict our visual outcome as well. For the surgery itself, we have, of course, all the strategy, as we said. We go for the macular hole when the vision become a little affected more and more than 20/70 or less, and we can see all for traumatic hole I can go, but now these things become a little bit changed. There is modification of this indication right now, which I said early intervention, which is symptomatic metamorphosis is an indication. I will not wait. I'll show you first example. When I have membrane, I follow the membrane, it becomes more and more symptomatic for the patient, so no waiting for this. Symptomatic also decrease in the visual acuity. No need to 20/70. Sometimes we operate on 20/30. If it is symptomatic, and I can see proofs of document with OCT documents of progressive, slowly even progressive disease, but it's progressive, so you have to abort the cycle. Although also early interference carry better prognosis, and of course the pharmacologic vitreolysis has its room in the selected cases who meet the criteria, and surgery with its modification for the rest of the cases. What is the surgical technique? It's simple. I just put it here for enumeration. We have to go for 3-port vitrectomy. Now we are going for with 23 or 25 gauge. Some people using 27. I no longer use it here in this country yet, but we use that for posterior vitreous detachment. You should completely detach the posterior hyaloid from the attachment around the disc by active suction or whatever. And then after that you can peel the hyaloid till the periphery. No need to do vitreous shaving at the base, vitreous base shaving completely, but at least to have the hyaloid. And then you have to stain the ILM. ILM is very crucial and important step. Many studies address that to do the whole only surgery without ILM and with ILM, and definitely removal of the ILM, it carry better prognosis of the whole closure because it elevate or relieve the tangential traction, not only the anteroposterior traction exerted by the vitreous. So removal of ILM is very important by staining. Of many types of stain, but stain, you have to stain. And after staining, you have to peel. How to peel it? Many studies, many techniques for that. But the safest right now is with the diamond dusted needle. It is diamond dusted, silicone tip was dusted with diamond. You can brush it. And now we have with lube dusted needle, not only needle, not to have a focal point of attachment, it's lube, so it's more safer to create an edge of this stained ILM. After creating an edge, I can peel it with any other forceps like end grabbing forceps or even serrated forceps. Any forceps you get familiar with it, you want to use it to peel it in circumferential way like rexus formation to peel from around the hole. Internal limiting membrane removal is crucial step to ensure the post-operative release of the tangential traction. It may be complete in a small hole or incomplete in large hole. In large hole, the technique right now, I have to peel the ILM from around the hole and to be reflected on the hole itself. So I will use it as roofing step to cover the denuded hole with the large hole. And of course, in this patient, when I'm doing my gas fluid exchange, air fluid exchange, I have to avoid completely to aspirate through the hole, not to pop off this flap which I reflected over the hole. Fluid air exchange, I have to do it, and you have to be the pitfalls here to avoid any aspiration through the hole, because aspiration through the hole may take off the part of the denuded photoreceptors or even the retinal pigment itself. And it will close the hole, but the visual acuity recovery will be bad for those patients. Many tamponades we use for this patient, SF6 or C3F8 or other things, of course, we put the patient in face down position. Show you this small video related to how to peel the ILM. This is the air fluid exchange. You can see peeling. You can see even the fluid goes over the nerve canal, and the glistening now of the air comes on the retina. After the air, I will inject the dye. And sometimes in the hole, to avoid the dye to go inside the hole, I have to leave some pocket of fluid, not complete air exchange. Then after you can see the stained ILM, it's glistening. When I press, it's glistening. So I create a hole, I create an edge, and I start to peel it like this way with my end grabbing forceps. I move here in circumferential way around the hole to avoid direct traction on the hole itself to go away. How far? Some people prefer to go up to the arcades, not necessarily in macular hole to go to the arcades, because the aim of that is to relieve the tangential traction. So when you remove it like that in circumferential way, it will be quite enough for that. After completion of our surgeries, it's full of pitfalls and tricks. But how about the post-operative position? In the past, most of the surgeons won't like the patient to put in face down position for the whole 2 weeks till the gas is completely absorbed, just to give support for the hole to close. But nowadays it's changeable. After many studies addressing that, they will try to shorten that time. Because basically, if you imagine yourself, it's very hard to keep in that position for longer time. Some people have some problem in the neck, some people have problem in the abdomen, even with the overweight of some patient, they cannot tolerate this for a long time. So, also supported, how it's supported with the OCT. When the OCT is the spectral domain, we have now intraoperative OCT, we have even immediate postoperative OCT under gas. It can tell me that in 70% of hole, the closure, it happened in the first day. Even in some studies, up to 90% of the hole, it happened in the first day. So as long as I achieve that, why I keep the patient for longer time in prone position. It's very difficult in that part. So tamponade, as we see, either SF6 or C3F8, this is on face down position as we see here, or silicone oil, of course, no need for face down position unless large hole evacuation could be through the hole. This is the face down position, and I said we can shorten this time as much as. The results. It's very encouraging nowadays, now with the advent of the technology and techniques and also the experiences. Smithy, which you consider the godfathers of the macular hole surgery, he's in Bascom Palmer Institute, and he did almost like thousands of macular hole because he is known for that. For impending macular hole, he reported an arrest rate of the progression in 80%. As we see here, he can arrest the progression of the hole by surgery early stage. For stage 1 hole, just they also report arrest of 90%. And in stage 2 hole, it reduced the incidence of the enlargement with better outcome in vision in 90%. Stage 3 and 4 hole can attain hole closure by 1 operation in 75%, with 2 operation in 87%. What's 1 operation, 2 operation? That means fails to close from the first trial. You have to repeat the surgery because we have some reasons. Maybe incomplete closure, maybe patient didn't attain the prone positions or face down positions, or incomplete tamponade. It can. So in 75% of the holds stage 3 and 4, it's closed from single procedures, and in 2 operation in 87.5 procedures as well. And thereby it appears an inverse relation between the duration of symptoms and the post-operative anatomic and the visual improvement for the patient. There is a percent of reopening of the hole up to 2 years after surgery, yes. So you have to follow your patient thoroughly after that. Possible cause, patient non-compliance. Inadequate tamponade from the start, production of traction by residual ARM. I don't remove it completely, or there is some residual. You can detect this with the post-operative OCT. Intrinsic retinal changes that cause stiffness. Some people, you remove the ILM, you remove the posterior hyaloid before, and you do complete gas fluid exchange with long-standing tamponade, and the patient can attain well stuck to the face down position, and in spite of that, you will still have failure rate. For those people, there is some intrinsic factor, and you have to tell your patient it is a possibility as well. So repeat the surgery, maybe with other tamponade like oil or something like that for those patients. Visual recovery keep improving even beyond 1 year. You have to keep that in mind, because many people assume that as long as or as soon as the gas absorbed, he will get maximum improvement of vision. No, we say this is the anatomical improvement of the whole. But for the functional, to the tissue takes place with the reformations of the layer of the retina, either the inner segment or outer segment, it takes even 1 year after surgery, and of course it will carry improvement in vision for the time as well. Trumpin published a successful macular hole closure without face down position in pseudophakic eyes. So he combined the hole closure to cataract extraction. He said that most of the macular hole almost happen after 50s with the idiopathic hole especially. So those people have some degree of nuclear sclerosis. So it's more wise to remove it, because we know that up to 3 years post-vitrectomy surgery, almost 100% of our patients for doing vitrectomy, they will experience cataract. How about if he has cataract from the start? How about he correlate between the pseudophakia and the closure of the hole? So he prefer, after 50 with macular hole, he will remove the cataract as a combined step to increase the rate of the closure of the hole for those patients. As I just said, post-operative OCT, it gave me a predictive criteria or about the prognostic factor about this whole closure. Yes, with the high definition spectral domain, it allows us to do intraoperative as well as immediate post-operative OCT under gas. Intraoperatively, it may modify our surgical technique. How modify our surgical technique? If I found residual membrane, I don't remove it. Still attach it at the edge, or one edge is elevated more than the other, I can modify the way of even tracting or the way of even. If I found with the OCT that it's more attached, for example, on the nasal, and it's released from the temporal, so I have to start peeling from the nasal to not to exert any more traction on the whole edge itself. So it can modify our thinking or our surgical strategy as well. Intraoperatively, it may modify, as I said, surgical technique and determine the needs for ILM peeling and any residual fluid around the hole. I can wait to aspirate. After macular hole surgery, it's very important. EIS, inner segment, and ELM, external limiting membrane line, are distorted from the perifoveal region towards the center of the closed hole. Therefore, measuring the length of the defect in the EIS or ELM line can be useful in estimating the retinal restoration after surgery. If you look at here and you look at this, follow these steps, you can see here, I can measure. This is a post-operative, but this is the steps of the healing. This is the preoperative hole, and this is how the hole is healed. And if I'm measuring the length of the inner segment, ellipsoid inner segment, EIS, or the ELM, which is external limiting membrane defect, it can give me the prognostic criteria for this patient. You can see here, you can follow here till complete healing of the last one. This is with the spectral domain OCT. I can follow the prognosis, how the healing process is going for those patients by measuring these two segments. Biologic modifier, what's biologic modifier? In the past, it was used. Sometimes you want to close the hole, so you add to some biologic things, autologous blood or something like that after centrifugation, to put it at the plug to close, to help in the healing of the hole. It can work, but it can lead to other disasters as well. If you look at this, years ago it was used by autologous blood on the hole, but it may lead to an eventual sequel. Here's the hole, if you can notice here, and here the hole with the red-free photos. That's preoperative. You see how post-operative? It's closed. I'm happy with that, but with a plug. There is a plug. This red plug is actually fibrous autologous plug closing the hole. So it gives me healing of the hole, but of course with very poor visual acuity because the hole is closed with fibrous tissue as if there is a hole. So that's the post-operative. Results have been reported as high as 100% for small series of cases selected with small short duration hole. We believe that 90% is a reproducible success rate within C3F8, 3 weeks of face down positioning and cortex cortex and ERM and ILM peeling. If I do that, I will get this percentage of 90%. And I have to follow up my patient as well because of the complications such as cataract, retinal detachment can follow treatment of macular hole, regular examination are necessary. Also, post-operative pressure elevation can be happen, pharmacologically can be reduced, failure for the whole of the closure or whole reopening. I can repeat my surgery or can modify my way of tamponading or retinal detachment if it happened, and the rate, post-operative retinal detachment reported from 2 to 14% after macular hole. Visual field defect. Some people have complete closure of the hole and who have visual field defect unexplained. Many studies are addressing that, and most of that goes to the flow of the cannula, infusion cannula, and the stream of the fluid or gas through the retina. It can damage the inner layer of the retina and give me that field defect that could be detected in some cases. So we have to be careful about the pressure rise for this patient. Cataract formation, there is a small risk, of course, of hole reopening the immediate post-operative period following cataract surgery because of the exerting traction during the cataract surgery. In 1994, Wendell reported a series of 253 consecutive eye undergoing repair of macular hole cases. In his series, 93% successfully managed with the only single operation. 60% of patients experienced 4 lines of visual improvement, and 84 patients experienced 2 lines of improvement. Within this group, 58 of the patient achieved 24 or better vision visual acuity. This is one of the optimistic studies. Use of ILM peeling may further increase the rate of single operation success. As I said, it relieves the tangential and it becomes now a routine step. It's not here a luxury. No, it's a routine step in our macular hole surgery. OCT imaging preoperatively or postoperatively has provided an additional prognostic data for visual recovery following macular hole surgery, and factor on OCT that predict the good visual acuity macular hole surgical outcome are as follows: the size of the hole itself and the traction on the edge and the measurement of the ellipsoid inner segment and ILM healing postoperatively. That's all predictive criteria. Assessment of the post-operative changes, yes, with the spectral domain, I can see if there is any residual pocket of subretinal fluid. I can assure the patient and tell him it will take months to restore, or any disruption of the outer retinal layer, which is RPE. If it is the case, that means permanent damage or irreversible damage is expected, or interretinal layer disruption also as well. Postoperative outer retinal layer integrity is associated with better final retinal sensitivity. While surgery for macular hole is considered elective, it's important for the patient to consider prognostically that there is possibly a risk of fellow eye to develop macular hole as well. That's in 12%. Take care. You have to keep examining the other eye. 12% to have the macular hole in the other eye. And if you have predictive, and if you have any membranes or something like focal traction with the vitreous, so early intervention for those patients may prevent the macular hole formation depending on the other eye history as well. We can see here some of the cases with the preoperative hole. I can see here a hole, grade 3 hole, with even cystic changes at the edge of the retina with preoperative vision 2100, and even 6 months after surgery, vision goes up to 2030 in this patient. That's in my series. Also here you can see here a lamellar hole with the vision. There is membrane, of course, lamellar hole, and the visual acuity go to 2070 with the release of this membrane and ILM as well. The vision improved to 2030 for this patient after 6 months of surgery. Here, stage 4 hole with wide separation, large hole as we see here, and with the cystic spaces at the edge of the hole preoperative 2200. It was restoration of the vision on this patient with single surgery, with proper removal of the ILM and proper tamponading. It reached after 6 months to 2060 visual outcome. That's from our series. Here's some also of our cases that before surgery is considered one of the good cases because it's small hole. Of course, you can see nicely how the retina is restored completely after surgery with 20/20 vision outcome for this patient. Also in this patient, that's macular hole grade 3 before surgery, and this is after surgery. You can see here also large hole here, the whole macular hole grade 4. You can see how big is the hole. It's more than 550 micron with complete posterior vitreous separation, and how's after surgery, 6 months after surgery with the restoration of the retinal anatomy. But of course there is some thinning out of the ellipsoid segment. Of course the vision recovery is not as good in these cases in spite of complete anatomical closure. Here you can notice the myopic eye. You can see the concavity of the myopic eye, and there is the secondary macular hole with a flat top. This is the picture of the myopic macular hole in high myopia, and this is how after healing or after closure of the hole 6 months after surgery with nicely restored central foveal anatomy. Summary for all of us. Of course, after all the time, I know it's long period, we know the diagnosis, differential diagnosis, new modalities of diagnosis, new modalities of changing the treatment strategy either by watching, either with new pharmacologic vitreolysis or with the surgical technique itself with its newly modifications. The summary, which is I want to be kept in mind that I have to know that idiopathic for thickness macular hole, I will be steady in that, are caused by traction exerted by the posterior vitreous on the neurosensory retina at the fovea. Disinsertions of its glial plug result in formation of a cyst. Avulsion of the roof of the cyst or the operculum lead to a macular hole. The neurosensory retina retracts centrifugally to form a full thickness retinal dehiscence. This is a pathology. Spontaneous regression can occur in 10% of the hole, so follow-up is important. But of course, if the hole is stage 3 or 4, it's very, very hard to stop the process spontaneously. The risk for macular hole development in the fellow eye in the absence of vice ring is 16, from 12 to 16% during the 5 years following the presentation of the first. The diagnosis and the staging of the macular hole is normally made on the basis of biomicroscopic. In instance diagnosis is doubt, Watsky, I can use it. Laser aiming beam, I can use it. Fluorescein or autofluorescence. And more recently and most important is the spectral domain of optical coherence tomography, which is OCT, either preoperatively, intraoperatively, or postoperatively to help me, to give me the prognostic criteria. Some examples here of visual acuity 2100, again, it's improved to 2025 after 6 months of surgery, proper surgery. Here in this with the membrane is evident, a macular hole grade 3, and here the follow-up of the membrane that preoperatively, and that is post-operatively improved to 2030. Rare cases, sometimes it happens. This is a normal pathway. I call it secondary macular hole. I just present some because it's rare cases. How it happened? Macular hole over foveal schisis. Yes, what's foveal schisis is separation of the fovea. You can see here, see the pigmentations around the arcades, at the edge of the arcades, with the foveal schisis, and there is a macular hole. You can see how big is the sciatic cavity. Of course, I cannot get the hole unless I go to the proper place. This is the hole in sciatic cavity. It's very thin, very difficult in surgery, but removal of ILM with tamponade is very important, and that is the post-operative for this patient. And I can get the vision in this patient kept a maximum 2200, and this is good on such patient which foveal schisis. Here's the other eye for the same patient. You can see only foveal schisis without a hole. This is a fundus photo, and this is foveal schisis without a hole. I did the same technique, which is PPV, as well with peeling of the ILM and tamponade to prevent the hole formation in the other eye, and it saves the vision also in this patient. It can need also with the detachment, chronic detachment, as is seen with the ultrasonography, total retinal detachment with secondary macular hole. And this is the hole, it appears in the OCT. You cannot reach even because the retina is separated, so the working distance of the OCT is 2 millimeters. You cannot get the edge of the wall of the globe. So you see only the separated retina at the edge of the hole here in this part. Hand movement vision, you have to take care of that. Sometimes you have vitreomacular traction with secondary macular hole. You see the hole here? Clinically, this membrane covering the hole. But with the OCT, it tells me exactly that I have a dehiscence underneath, and I have to deal with this as a macular hole. So this is vitreomacular traction with secondary macular hole. Vision is 100, and this is how the hole appear after removal. That's intraoperative pictures, and 400, and this is 6 months after surgery, and it's 40 when I restore the macular hole with the proper technique. Another also cases of the macular hole secondary to retinal disease, like here, Irvine-Guss syndrome. You can see here diffuse macular edema with cystoid edema after cataract extraction. The vision is 2 meters. And with the progression or following the progression, we can see here more collapse of the central cyst is about to rupture, and is actually ruptured, lead to macular hole formation. So proper treatment of that hole with peeling of the posterior hyaloid as well as the ILM, it can take the retina like this with the vision up to 20/60 after surgery. So also here, I have not to wait along for macular hole formation. If I'm interfering earlier in the cyst formation, it may carry a better prognosis for this. So this is macular hole post-Irvine-Guss syndrome. And finally, you can see here this patient with focal traction, impending cyst rupture with the focal traction, and here after removal of the membrane by surgery with residual fluid underneath the retina was 400, and still after also 6 months, you still have this fluid accumulation due to late interference, hole formation due to ruptured cyst intraoperatively. At the end, this is some of presentation of the rare cases as a whole, as well as the basics. I wish what I'm saying is kept in mind with the new technique of diagnosis and management as well, to get the best prognosis. So in the best hand with the macular hole surgery, you can regain most of the patient useful vision without any implication, either the patient life or the economic standard of the community as well. Thank you for your hearing and attention as well. Thank you very much.